So we move on to, after seeing all this, we move on to anterior vitrectomy and IOL placement options in these kind of cataracts. We have seen quite a few, so I'll skip through some of my talk. So anterior vitrectomy. So in subluxated cataracts, some cataracts will have vitreous in the AC to begin with. Some we will get vitreous inside when you start doing phaco or when you are through the phaco. So whenever there is vitreous in the AC, complete a vitrectomy and then proceed with phaco. That is the golden rule. So here in the beginning itself there is vitrectomy. So irrigation and vitrectomy. So through the main incision there will be leak. So it's better to do a vitrectomy through perfect fit side ports. And adequate vitrectomy to clear the anterior chamber alone. Don't keep pulling vitreous from wherever there is a dialysis. Don't go into the dialysis area and keep on doing. You will lose vitreous support. It is very, very important to have vitreous support for these kind of subluxated lenses to be held there during surgery. Once it is done, as madam was showing, the viscoelastic which is injected is very, very crucial. Viscoelastic is not just HPMC. So see in this case, there is no vitreous here. But this is a large area of dialysis. From anywhere through that area you can get vitreous coming out because of the irrigation, aspiration and all which happens. So I would use Viscoat or Orocoat Plus. No financial interest in any of this, but these are the dispersive ones which will remain in position. Cohesive ones will get aspirated off immediately when you go near it with the aspiration port. So your phaco should be slow motion with low flow rate and aspiration, but still if you have Viscoat lying there plugging that area, you can see that I am putting in Viscoat from the opposite side and plugging that whole area, and after that I am comfortable doing a Rexis with the HPMC inside because the feel of the capsule is better, or I am used to it if you put in HPMC. So as madam was telling, having a Paka Rexis is the prerequisite to continue with the phaco. Otherwise, forget about phaco. In a subluxated cataract, forget about phaco if you don't get a Rexis. So here, as it was shown before, it's a diffusely weak zonules. Traumatic, so not progressive. So here again, the capsule is held with the iris hook itself. You can. Only thing is, when the chamber fluctuation happens, if it is not a capsule hook, it may just come off. When it deepens, it will just come off. So that is one disadvantage of iris hooks. So the advantage is that madam was showing in the last video MST hooks. MST hooks are much more friendly than the initial ones which were shown, Indian made ones. They are costlier, but we can reuse them. They are broader, they go long towards the equator, and the idea is to support the equator, not to just hang the Rexis marker. So that we have to be very clear about it. The tip has to go hit the equator, and the equator is being pushed with the capsule hook. So here this is subluxated zonules in pseudo exfoliation. So here you can notice that I have held the pupil with 4 hooks, then I have held the Rexis margin with 4 other hooks and completed the phaco. So after this we need to know, see, as we were all talking and we are seeing nowadays that 10 years, 15 years after your pseudo exfoliation phacos, many of them come with the decentered IOL. Almost every week I see one with decentered IOL bag complex. So they all decenter mostly after surgery, especially after surgery. Before surgery, without surgery, the lens remains there. It dangles, but it remains there. But after surgery, the Rexis contracts and the peripheral zonules are weak, and zonules keep giving way, and the phimosis and the contracture of the bag will accelerate this process. So here we will have to put in a capsule tension ring. So while putting in a capsule tension ring, I am having my hooks on so that the bag is stretched. So the second, the trailing part of the ring, you can use a Sinski, or I would use now a micro Rexis forceps. We can hold it till the end, till the Rexis margin, and leave it and guide it with your Sinski. That is what I do right now. Now I remove all my 4 hooks from the Rexis margin so that I can put in the IOL. But these iris hooks remain on the pupil because visualization is very, very important. Don't do anything under the small pupil area. And the 3-piece lens, I now prefer the Oro View 3-piece lens, which is 13.5 millimeters, half a millimeter bigger than any other 3-piece lens available, or a Technics 3-piece is also fine. But to remain in the sulcus, the larger the better. But once in the sulcus, For long term, it is better to capture the optic in the rexus margin. So here I tap one half of the optic underneath the rexus margin, and now we can see that there is a lot of visco inside. So while placing the IOL, I put only sodium hyaluronate, which can be easily and completely aspirated off. So that has been irrigated, and even you can aspirate also. Later on, you will get a lot of capsular bag distension if you leave visco inside the bag. And now the other part is also nudged into the bag, and now this remains on top of the bag, and this phimosis also prevented or reduced a little bit because of the stretch at two corners. So that prevents or reduces the rate of phimosis, and both these together will reduce the later decentration and dislocation. So now during the surgery we could see movement there, and there was vitreous. So here again I stress, please do vitrectomy, but do only enough vitrectomy to clear the vitreous off from the anterior chamber and plug that area with dispersive viscoelastic. Because the more you do, the more the lens will flutter and move backwards when you get in your phaco probe. So once that is done, I don't want to show the phaco part of it because it was shown, and I finished the IA, and then just try to identify, the pupil becomes small, and then identify where is your rexus. So this is the rexus is good, and it was all going fine. I thought the bag is also stretched with viscoelastic very much, but when I was just trying to aspirate, see the bag separating off more than 180 degrees of bag subluxation. So here again I felt, because it was the intraoperative, I could get away with the CTR, and regular CTR goes inside the bag, nothing new about it. The lens also goes into the capsular bag, and it is very well centered and nice looking at the end of this one. So after many months, the same patient comes back to you. Don't go anywhere, we'll come back to you only. And then move your head and show. See, dangling, something is moving. Whenever I'm looking top, fan is rotating, fan is moving and all. So now what to do? We will have to fix it. You can tell that you did something. Did you not rub your eye hard when something went into the eye? Oh yes, 1 or 2 times. That is the reason, that's all. You can find a reason very easily. And then you put in sodium hyaluronate in front, and we can see the lens is just floating. But we have the CTR inside, that's a great advantage. So once you have the CTR inside, we can fixate this along with the bag. So that is what I want to show. I don't want to mix vitreous with this. So put a sodium hyaluronate under the bag also. So this flap need not be that big, but at least 3 millimeter long flap is needed. And marking 180 degrees, very, very crucial. Otherwise you will get a tilt or a decentration after you fixate the IOL. So marking 2 millimeters behind the anterior limbus and going in with a 27 gauge needle. So your 27 gauge needle and your 90 Prolene needle should go in. After entering both needles inside, you will realize that the needle is not going into the hollow of the hollow needle. So make sure that your Prolene needle will go into that first outside, then do this. And the needle is placed behind the complex, and the Prolene needle pierces the bag and comes out, and the same thing is repeated on the other side. This time the hollow needle comes above the complex, and the needle goes again back through a paracentesis, and this will form a loop, and you can pull it on. And now just give a little traction and center it, and you can decenter it a little bit so that you can see this part more clearly. And for better visualization, these two hooks are placed on either side of the flap. That is very crucial. And after doing this, don't tie now. Make 3 throws and make a knot and make the other side and see how centered it is. And don't lock. After centering it, then lock. Because once you tighten and center, you will see that it is decentered to one side, and the next side if you pull, it will not center itself. So then you can have a centered complex. So this one was already shown. Once you place a CTR and the lens inside, if you feel that it is not centered, you will have to fix this, because it is not going to be centered, and later on it can get further decentered. The same thing which we saw, the Ahmed segment, which is very useful just to get into the area where it is maximum subluxated, and the same kind of railroading which we saw before. The two loops go in, and then you don't have to pull too much. Make sure that the two Purkinje images on the cornea and on the lens will match, and when you place the eye straight looking ahead. So this is again the Zioni ring, not very hard to get, but then it's difficult to use to put it inside through the main incision, and I would nowadays not use this. I use a CTR and then use a CTS along with it rather than using this, because it is a little cumbersome and difficult technically. once there something goes wrong, you lose the whole bag and the whole procedure is lost. So I don't want to promote this by showing this again. And if you are not okay with all these and the subluxation is too much, the other option is to place, to take out the whole bag and do a vitrectomy and place anterior chamber lens, iris clip lens, or a glued IOL or a scleral fixated lens. Iris clip lens has been shown by madam. I personally don't do it, and that's why I am not showing it. I have nothing against iris claw lenses. Please continue to do if you are okay doing with this. And it is not yet time to right away AC IOLs. This is what Dr. David Chang himself says. He said that 10 years before. He said that 3-4 months before in the Andhra Pradesh annual meeting when we had his virtual conference. So I personally asked him at that meeting itself, sir, don't you have that reference with you? He said, yes, there is a meta-analysis published in ophthalmology telling that if you do everything properly, AC IOLs have the same outcome on long term as the scleral fixated. Iris fixated is not studied because it has recently come, and so that's not there. So it is very important to do a complete anterior vitrectomy. Even if you do not have a vitreous loss, I will do anterior vitrectomy for AC IOL. That is one. Second thing, we should have a pupil which will contract and at least reach 5 millimeters. And the third thing is sizing. So measure your white to white properly, see which is the maximum and which is minimum, and you should have at least 0.5 to 1 millimeter larger overall sized AC IOL with you, and then doing a proper vitrectomy, proper iridectomy, one or even two. If you are not sure about one, make two. So you have your lesser cut rate and use your vitrectomy probe itself, and this is not the right thing to do. Extending on the cornea 5 millimeters, not the right thing to do. So please cut backwards into the sclera and then make scleral pockets and extend, or go to a different location, abandon this corneal incision. And the lens always comes with the angulation facing down in the package. It is packaged like a PCIOL. PCIOL is also angulated backwards like so. The optic of the anterior chamber lens should be facing away from the pupil. You don't want to have pupillary block even though you have a PI. So tilt it, flip it once you take it from the, once I flipped it and I forgot whether I flipped or not. After taking it out, I just took it out. I usually take it out just like this, like flipping it automatically. Later on, once I placed, it looked like it was not flipped. And it's very difficult to identify in the anterior chamber once it is placed. I asked my PG, did I flip or not? What is flip, sir? He doesn't even know what is flipping. And so this is what I am telling. So when and then I asked my assistant nurse, did I do that flip? She said, sir, ഞാനത് തുറന്നപ്പോഴേ അതിങ്ങനെ വളഞ്ഞിരിക്കുകയായിരുന്നു സാർ, പിന്നെ സാർ അത് തിരിച്ചോ ഇല്ലയോ എന്ന് എനിക്ക് അറിഞ്ഞൂടാ സാർ. No, what to do? So I finally explanted that lens, took it out and saw the alignment. Okay, anyway, actually it was flipped. But then anyway, I took it out and placed once more. Because I have seen a patient go total optic atrophy, glaucomatous optic atrophy, just because there was no PI and a reverse placed AC IOL. Patient did not know. Some rural patient came with GOA, and this is the only reason. So always the placement part and the PI is very, very crucial. And now we need to place it. If you think that you have 12 millimeters, and when you place horizontally, it is feeling not that very tight. When you touch it, leave it, it is not springing back. It is just moving a little bit when you tap it. So then place it vertically. So vertically, if you go, you have a 0.5 millimeter advantage. So rotate it and place it. So when you are rotating, it can be rotated either directions. But make sure that the open end does not go into the PI. So sometimes it goes into the PI. So lift it and place it rather than rotating it. So nobody else to talk here. So we'll go on 5 more minutes. And then again, suturing is very important. If you feel that your tunnel is not great, please do suture, because that is very, very important. And ECC sections, if it is ECC, people used to say not to place the haptic just under your ECC wound. But in a tunnel, I don't think it's a big deal. It's a problem placing the haptics underneath your tunnel if you have a good anterior corneal entry also. And if it is loose, if it is smaller than your white to white, that is more problematic. There is more pseudophagodonosis, and the pseudophagodonosis itself can cause aberrant currents inside the anterior chamber. Need not directly touch. It can cause the direction of aqueous flow inside. it's all turbulent always, and it causes long-term endothelial damage. Otherwise, endothelium, nothing happens to endothelium. So once moving on to glued IOL, it is very important to know few steps. Okay, so marking 180 degree, very, very important. So this is a good instrument to mark your size of the flap. So if you are placing this glued IOL, I nowadays do only 2 millimeter by 2 millimeter. So 180 degree opposite is very, very crucial. So 2 millimeter and backwards 3 millimeters. So AC maintainer, either you can use your AC maintainer, or I nowadays use the trocar cannula, which is used by the retina people because it stays in more tightly, and then 2 millimeters behind, and see what size of forceps you have, and the opening should be enough to get your forceps inside, 23 gauge or 25 gauge or whatever. And then one paracentesis, and your incision has to be 90 degree opposite to the flaps which you have made, very crucial. And then hold the tip, don't leave, and then keep injecting. While injecting, do not lose view of the tip, otherwise we will sometimes loosen it off. Keep it tight and let the whole optic go inside, and then flip your trailing haptic properly, and then bring out. Once it is brought out, I didn't show you that, but then there's a silicone stopper which is introduced in the iris retractor hooks stopper itself can be used. That will retain this one, that it will not go back. And this is the handshake. To get it inside, hold not at the tip, but hold it away from the tip, and once you get the forceps on the other side, again hold at the tip. Otherwise the tip will get deformed and you won't be able to tuck it inside. And once it is taken out, then you loosen this silicone tip, and then I first, after bringing it itself, I get it into the scleral pocket. I'll show that pocket next after this. And it is tucked on both sides. Tuck it, retuck, center it properly, and close. The incision can be closed by suture if you think that it is leaking. Otherwise, it need not be. And all these incisions are hydrated. Make them leak proof. And then use the glue. If you have glue, use glue. But glue has nothing to do with holding the IOL in position. It's the pocket which keeps it in position. If you don't have glue, no harm. You just suture the flaps with nylon suture, and then I put air inside so that there is no leak through the ports, and it has to be dry while applying the glue. And once it is done, it can be used for the conjunctiva also. But nowadays I suture the conjunctiva also because many cases it tends to retract. So I don't want the flap to expose and all this. So there is another, this is the Chariot's pocket, which is very crucial. It has to be right next to your sclerotomy opening, and use a 26 gauge needle or even a 1 millimeter slit knife is also fine. It need not be so tight fitting for the haptic. It can be loose inside. It doesn't get decentered. And this is the new lens which has come up, made in India, Appasamy. It is the CMT Flex. Gives you some advantage in haptic positioning because it's a T. You can see it is a T at the end, and this loads like a regular IOL in a butterfly cartridge, and the T should be placed straight, and it should go into the nozzle here and folded like the regular IOL. And it's a modification by Dr. Nivian from Chennai. And see the tip coming up, and then inject. Here the difference is that the incision has to be slightly away from the center because holding it will be easier, and the flap size is larger, 3 millimeter by 4 millimeters, so that the tip gets nicely buried there. And once the tip has to be held, the center, not the edges, it has to be held at the T tip. Once it is held strong, inject completely, and then retract this. I will show you in the other video. And the next side also, hold at the junction and exteriorize it. And this was not there in that video, and that's why. So once it is held and pulled, you can notice that it gently comes out, and once it is out, it just sits there. See that? It just sits there. You can leave it there. No more tucking, nothing. And the other side also, hold it and bring it out, leave it, and that's it. It remains flat. It closes the sclerotomy opening. That's very, very important. It doesn't leak at all. And nowadays I make a scleral flap thicker than normal because it's a slightly thicker part of the T, and it should not erode out through. So it doesn't erode if your section is nicely closed. Either you can use, it doesn't leak. You don't have to close it for the leak part of it. but then use glue or suture and close it. This is also less time consuming. In my part, the tucking of the haptic is a little cumbersome for me. This is giving me much better tucking of the haptics, and